Greetings. My name is Chantapram, and today's video I am going to talk about the pinnacle of the life-saving device that even saves so many severe cases that require crucial assistance on heart or lungs, and that also includes the hard time of COVID pandemic, the ECMO, extracorporeal membrane oxygenation. If we translate directly, it means oxygenating blood via a membrane which is located on the outside of the patient. Now, the first development of the ECMO began in 1953 by John Gibbon, successfully using cardiopulmonary bypass circuit to repair an arterial septal defect in 18-year-old patients. And later, in 1955, the development of bubble oxygenator invented by Richard DeWall was introduced. However, this early bubble oxygenator caused hemolysis, the destruction of red blood cells, limiting its potential. And finally, in 1957, the development of silicone that allow for efficient gas exchange has been introduced, and the development of membrane oxygenator along with ECMO has begun. The first successful use of ECMO in the ICU was reported in 1971 by a patient with severe lung dysfunction after a motorcycle accident. Since 2000, ECMO has begun to spread across the world until today. It will act as a resuscitation, become a temporary heart or lung for the patients, maintaining the blood flow and oxygenation by the patient cannot perform the function by themselves. The patients that are gravely ill with severe cardiac failure, severe respiratory failure, or both also belong to this case. The same concept can also help the patient as the bridge to transplant or surgery, but for the larger scale, we use the heart-lung machine. And if the ECMO does not have the oxygenator compartment, it will consider as a short-term VATS or ventricular assist device, where it only supports circulatory system without heating or cooling capabilities. Keep in mind that the ECMO is not any source of treatment. It will not treat any infections or fix anything that's wrong with the patient in the first hand, but instead it is a form of a life support system that borrows the time until the circulatory or respiratory system will be healed and function properly, like good as new. As its mechanisms, it will remove low oxygenated blood from venous and oxygenated it again, warm or cool it, and send it back to the venous or artery depending on the case. In addition, the anticoagulant agent, the substance that prevents the blood clotting, is required to be injected on the patient since the blood here contracts with the foreign material. In this case, it's circuit. We have the pump, we have oxygenator, which has a tendency to clot. And these blood clots can be fatal for the patient if not controlled. So basically, this device's objective is to preserve the end organ perfusion. So how does the ECMO actually works? Inside the ECMO circuits, we require these components: the pump, the oxygenator, the heat exchanger, connected by drainage cannula that drains the blood from the patient to the circuit, and the return cannula that returns the blood back to the patient. So let's talk about the cannula first. The cannula can come up with many different sizes and lengths. The usage depends on the location of the cannula that is need to be set up along with its purpose. There are several specifications that we need to know, such as 1. The cannula insertion site and positions. We can insert the cannula on the femoral vessels, aorta, right atrium, or internal jugular subclavian, or even an axillary vessels. 2. The size of cannula that depends on its duty. The venous cannulas are generally larger lumen to allow better drainage and longer, while the return cannula are smaller and short. The next one is the heart of the ECMO, the core that makes everything works. It is the pump. There are many various types of blood pump that exist today, but the most common one of the ECMO pump is centrifugal pump, where it will move the blood by the rotation. The centrifugal pump converts rotational energy from a rotor or the impeller spinning between 2000 or 4000 rounds per minute, depends on the design, into a kinetic energy of at least 100 millimeter mercury as the minimum requirement of head pressure at 5 liters per minute. Keep in mind that the pump design must be concerned with the hemolysis, where the critical high shear stress causes red blood cells to rupture, the window the ability to escort the precious oxygen to the body. In some cases, if the hemolysis rate is off the charts, the patient will die. Meanwhile, too low shear stress distribution can cause a thrombosis where the blood clot can easily occur, and as mentioned before, it can block the circuits, it can harm to the patients, and it's really fatal, or even cause a stroke. So in order to measure the correct input and output of the pump, we require to set a manometer or pressure sensors to measure its head pressure that the pump is currently producing. Oh, I forgot to mention, the head pressure here is the pressure that drives the blood across the circuits. The pressure sensor or manometers will be placed on the inlet of the pump or the venous drainage cannula. This one will show a negative pressure in the display, so it's basically the amount of work that the pump needs to do in order to drain the blood from the patients. Another position for the pressure sensor is the outlet of the pump just before the oxygenator. This one will show the positive value measuring the amount of resistance from the oxygenator. The last position of the pressure sensor is at the outlet of the oxygenator. The pressure value will also be positive value, which signifies the amount of resistance past the oxygenator to the patients. So both pre and post oxygenator pressure sensor here can be used to calculate the change in pressure that occurs within the oxygenator itself, which can tell us whether we have a blood clot or not. So the next part is the oxygenator. This compartment contains a large hollow fiber membrane. This fiber can mimic the duty of alveoli in our lung as a gas exchange. The hollow space will be where the oxygen stream located, while the outside of this hollow is where the blood is flowing. Once the blood is completely flowing through, the oxygenator will have these membranes layer wrapped across the entire body. The gas exchange will occur across this hollow where the blood will be replenished with oxygen through diffusion of gas and remove carbon dioxide from the system. This compartment also acts as the resistance that goes against the blood flow, which means the more head pressure generation demands on the pump. To control the rate of gas exchange in oxygenator, the sweep gas control must be maintained. In order to achieve that, we need the air blender station and a flow meter station after the oxygenator. Now let's talk about the sweep gas. The sweep gas is a source of oxygen used for gas exchange in the membrane, lungs, or oxygenator. The gas component can consist of ambient air with 21% oxygen, or it can be pure dry oxygen. In other words, the sweep gas allows for removal of carbon dioxide in an efficient manner. Meanwhile, the flow meter here will control the sweep gas flow rate, which can range between 0 to 10 liters per minute. The next part is a heat exchanger. Its job is to control the temperature of the patient. So, in other words, it controls the blood temperature. The heater is a water-based heater, will be constructed within the oxygenator and rewarms or cool the blood before being infused back into the patient's circulatory system. So in summary, we have drainage cannula, we have the pump, we have oxygenator that connects to the control system, and we send the blood back to the body via the return cannulas. And lastly, we also need to attach the flow meter at the outlet oxygenator too, to measure the flow rate of the blood before it goes back to the patient's body. Next one is the configuration of the circuits. The configuration of ECMO circuits can be different, depends on the condition of the patient. In other words, which system does the patient needs to support. The ECMO configuration can be separated into two types, VV and VA. Let's talk about VV first. The VV connections mean veno-venous. This formation is used for respiratory failure patients while preserving cardiac functions. For instance, VV ECMO can be used as hypoxic respiration failure, where you don't have enough oxygen in your blood or ARDS. There are two configurations, peripheral cannulation or central cannulation. In peripheral cannulation, the drainage cannula can be placed on internal jugular vein, femoral vein, subclavian vein, or axillary vein and return to the same vein where it's attracted. For instance, if we connect into internal jugular vein, so we will return it internal jugular vein too. In central cannulation, however, we connect the right atrium of femoral or internal jugular or subclavian vein to connect with the right atrium or pulmonary vein. The VV connections allow us to promote a protective lung ventilation. Protective lung ventilation aims to decrease the incidence and severity of ventilator-induced lung injury associated triggers such as varotrauma, barotrauma, or at-iliac trauma. Support gas exchange when the lungs cannot and provide the organ with vital arterial oxygenation. It will drain blood from the vein, send it to the oxygenator to remove carbon dioxide and send it back to the patient's right atrium via the vein which is right before the heart, providing oxygenated blood for the heart to pump past the failed lung and onto the rest of the body. One thing that is really important is to monitor these patients for right heart failure, especially in case of ARDS. We learned that high VV ECMO blood flow may cause pulmonary hemorrhage. Furthermore, it can invoke the symptoms called cor pulmonary when a lung issue causes your right ventricle to get too large to the point that the heart starts to fail. When that happens, we need to change the ECMO configuration to the next one, and it is the VA ECMO. It means veno arterial. This formation is used for cardiac failure patients who cannot pump the blood across the body, and you can also get respiratory support from this configuration since we got the oxygenator in the system as the default. So in this configuration, we will get the flow of condensed oxygenated blood to perfuse patient organs and body too, unloading the failing heart by reducing preload. So we are now providing perfusion of the oxygen for the body when the heart is not able to do it by itself while unloading and resting that heart. For instance, we have VA ECMO for refractory cardiogenic shock where the circulatory system fails, resulting in organ hypoperfusion unresponsive to conventional medical therapies. There are also two cannula configurations here, so let's start with peripheral or two separate cannula circuits. In this case, we will place drainage cannula at the femoral vein or right internal jugular or similar to VV, but instead of returning the blood to the right atrium, we will return them to the femoral or axillary artery which is right after the heart. This position can provide the blood flow not only going down for the lower limb but also retrograde flow up of the aorta, but we need to be aware of limb ischemia since the lower leg will not receive sufficient blood flow. So we may require another cannula outlet to the another side of the artery. Now, the second formation of VA is a central cannulation, which requires a full open chest procedure. The patient will be left with an open sternotomy. So we will have cannula inserted directly to the right atrium as well as ascending aorta. And here we drain the blood directly from the right atrium and return the blood to ascending aorta. The VA has no risk of recirculation of the blood, unlike the VV that have, since the blood that we drain comes from two different systems. In other words, we will bypass both respiratory and circulatory system. All in all, the ECMO is an omnipotent device for saving lives with both cardiac and respiratory failure, with the ability to borrow time for the patients to recover from their illness. However, there is a risk that we need to be aware of. Firstly, the survival rate of ECMO is around 50 to 70%, and it can be as low as 30% for prolonged use. The ECMO can also cause infection or fatal sepsis, which is life-threatening, that can occur for excessive use. Excessive bleeding to pulmonary or brain from exceeding anticoagulant within the bloodstream that aim to prevent the blood clotting is also the case. Also include the seizures or stroke, are also possible if not managed properly, and even death is all accounted for, so we must be aware of. And that's it for today. Thank you for listening.